Assalamu alaikum.
Assalamu alaikum. I think let's wait for a few minutes. People are still joining.
Yeah, I would request people to turn on their videos and mute their microphones unless you have a question. And again, we will, if we have any questions, Dr. Suhail will ask by person, by name, to answer the question. So one at a time, we can get involved in this discussion, inshallah. Okay?
Inshallah. Shall we wait a couple of minutes?
Yeah, we have 6 people joined so far.
Let's wait another couple of minutes because lots of people said Tuesday is fine. So hopefully we'll get more. Chale, I think करते हैं start.
Okay, let's start. Bismillahirrahmanirrahim.
Assalamu alaikum, everyone. Can you please turn on your cameras so that I can see you and keep your mics off? Thank you. Sarah, Asya, Shiraz, Rao, Ruxana, and Gulizara. I can't see you. It's good to see faces, and it looks more interactive. Whom am I talking to? Good. Okay, so Assalamu alaikum, everyone. Last time we discussed ABCD approach and ALS protocol. So I hope you had a chance to read through, or if you haven't been in the previous lectures, then there was an online link. So what we will do today, I thought, because it was all like when you read a book, but we'll try to put it into practice today by putting into a scenario, and then we'll see how we can treat in actual situation when we go into the situation like that, and then how can we treat that patient. So don't worry, if you don't know, just say, just try, participate. This is the good time to ask questions. If you have any concerns, just rather than when you are in that situation and do something wrong and don't know what to do, it's better to discuss now. Are you agreed? Okay.
Yes.
So if I say you've been brought, a family has brought a 70-year-old male who is coming with a little bit of shortness of breath, not feeling very well, and he's looking sweaty and clammy. He's having palpitations, and his heart rate is about 220 per minute, and his blood pressure is 90/60. And when you go close to him, how are you going to start your initial assessment? Like I said previously, you don't really need to know the actual cause of their concern or the actual diagnosis on the spot. So how will you start your initial assessment of this patient? 70-year-old, coming looking very unwell, short of breath, heart rate of 220, blood pressure 90/60, and he looks unwell. So Gulizara, I can see you only. Can you just start your initial assessment? How will you approach the patient? Asya, can you please turn your mic off? Okay, thank you. Yes, Gulizara.
I would start with the ABCD protocol. So
Good.
I would look if containing his airway, if he has rolled back his tongue or anything of such sort, if he has a trauma or anything. So
what's the first thing you do to assess the airway?
I check
You
for
don't go and start looking into the mouth. What do you do to assess somebody's airway?
Auscultate. I'd auscultate.
No. Auscultate comes in breathing. You will talk to the patient.
Okay.
Yes. So when you talk to the patient and patient says, oh, I'm feeling very unwell. So what I'll do is if I keep prompting you, you keep asking the questions, and I will prompt you that what is actually happening as you go along. Then you will have the idea that what you are doing. Is that clear now, everybody? So you go and talk to the patient, and if he says, oh, doctor, I'm really feeling unwell, what does that suggest?
That he's maintaining his airway. So to begin with, we know that A is fine. So we can proceed to B.
Okay. So is there anything that you can add to support his airway?
Perhaps his neck position, or how the way his posture is.
And then you can apply some oxygen. Yes. So because he's already feeling short of breath and he's talking to you, so it means his airways are patent. So you can help him to support a little bit more so that he may not deteriorate. Right? So you give him oxygen, and then you decided to proceed on to B. Rao, can you hear me?
Yes, I can hear you.
So can you tell me how will you assess B in this situation?
In this situation, I would like to do the complete respiratory system examination, and
which includes
inspection, palpation, percussion, auscultation, and inspection. I would like to see the movement of the chest, whether the chest is moving bilaterally, or is there any if the patient has trauma or anything, there's flail segment.
Seher, can you please turn off your mic? Okay, so you are listening to the chest. What parameters will you look for to assess the breathing situation?
On auscultation, I would like to check the air entry, whether the air entry is all over the chest
So
bilaterally
air
or not.
entry is equal in both sides.
Okay. And then I would like to see other other added sounds, like if there is any wheeze or crepitations.
So his chest is almost clear. You can hear breath
Yeah.
sounds equally, and
Okay.
his chest is moving. Anything
Okay.
else?
And then I would like to see the position of the trachea, whether it is central or pulled anywhere on the right
Very
or
good.
left. And I can
Okay.
also check the jugular veins. I can see if the patient has distended veins.
Just a second. Seher? Seher, can you please turn off your mic? Thank you. Yes, Rao. So you have auscultated, chest was equally moving, trachea was central, and he had no added sounds. Anything else in the B?
And
So you would like to know what's his respiratory rate? Yes.
yes, saturation,
So
oxygen saturation, pulse oximetry, yes.
yes. So these are two very important numbers which will tell you that how much patient is breathing. So if I say his respiratory rate is 40 per minute and his
Okay.
saturations are 89% on oxygen, which Gulizara has already started on oxygen. At this point, would you be worried about this patient?
Yes, I would be worried.
Okay, so yes, you need to be worried because the parameters are not good. Okay, but at this point, you have decided that his airway is patent, you have given him oxygen. You also need to look at what is the effort of breathing. Is he really struggling, getting exhausted, or what posture is he in? Is he going to collapse or what? Then how can you help him to get better? So in this case, positioning may help, slightly upright to get his breathing a bit better. And he's got oxygen already. So you have
Okay.
got increased respiratory rate. His SATs are really low. Yes. And then you move on to C, because at the moment you have given him oxygen and no chest findings were found on auscultation. Sarah,
Yes.
can you tell me what can you do on C? Sarah, can you hear me?
Yes.
Okay, it's Zara or Sarah, anyone?
I'm sorry, I just joined.
It's okay. So we are talking about a sick patient who is looking very unwell.
Yeah.
And he's come to you with a heart rate of 220 and he's looking short of breath, clammy, sweaty. And Gulizara has started initial assessment with ABCD approach. She looked at the airway, talked to the patient, which was clear. He talked back to Gulizara. So she realized that the airway was patent. So she gave him oxygen. And Rao has done B assessment, trachea central, bilateral equal air entry. His breathing rate was 40 per minute and his saturations were 89% on oxygen. So at the moment, we haven't found any obvious cause to treat. So we move on to C. So can you tell me what can you do in C?
Okay.
What is C for?
So C, I would like to pass an IV line.
Okay.
But at this patient, if his pulse is in 200, I would like to attach
Sorry, can't hear you
so
very
as to
well.
check. Sure. So in C, basically, I would like to do two things. C is circulation. So I would like to establish an IV. I would like to check the BP, and I would also like to start fluids in case. So in case his BP is lower, either ways, with a pulse of 200, we should start fluids. But other than that, pulse is 200. So I would also like to attach the pads for either automatic defibrillation or else the ECG, so that I know the rhythm is.
Okay, good, well done. Memuna? Memuna, can you hear me? Okay, Mahmood, can you hear me?
Yes, I can hear you.
So when Zara attached the monitor and the blood pressure cuff, so blood pressure was 90/60 and his heart rate was 220. Are you concerned at this point?
Yes, I will concern. I will firstly check the pulse because the heart rate
So
is too much.
yes,
So I have to assess the pulse. The pulse is palpable or not.
very
Sometimes the
good.
VT is come with pulse, and sometimes it's come without pulse. And sometimes our cardiac monitor, the ECG leads identify the vibration, and they appear a rhythm on the cardiac monitor. So
Well done.
uh, the patient have a high rate, so I have to identify the which kind of the rhythm they have.
Good.
So it might be a
So
SVT,
what can it
it might be
be?
a VT.
What can it be if not VT?
So if it is at 200, so it might be a atrial fibrillation or atrial flutter.
Okay, it's regular and it's
Uh,
220.
so so if it's regular, then it's not be a atrial fibrillation. So it will be a SVT or atrial
Good, well
flutter.
done. Okay, so
So
we established on the monitor that he's got monophasic lines, which is VT. So
yes,
what's the first thing
okay.
would you like to know when the patient has got VT?
So with the VT, I have to
You
assess the
already did
pulse.
that. You checked for the pulse.
So the
Yes.
pulse is
So you
present
did
or
that.
absent.
So now we have realized that the problem is at the moment that we need to deal is his circulation.
Yes.
That his heart is not doing the proper job. And that's why because of that. Everybody agreed?
Yes,
Okay.
here the one more thing is that uh, the patient have the high rate, and the patient GCS is a complete and maintaining airway. So it's mean uh, the increased heart rate is affecting on the blood pressure and oxygenation pattern, but the GCS is maintaining. So we have some few time to take immediate action.
Okay. So that's good. So while you are assessing, you're checking his pulse, the patient suddenly collapses in front of you. So Rao, you have seen the patient suddenly go faint or
Okay.
unconscious.
Okay.
So what is the
Uh,
first thing you would like to know?
I would like to go through the ABC again. I would
Okay.
shake the patient and ask him what has happened, or is he all right? If he does not respond me,
Patient is not talking to you. He's
okay,
unconscious now.
okay, and I will check if he is breathing or not, whether the chest is rising,
Okay.
and if that is not happening, then I would like to check the carotids, and if carotids are whether present or not. If they are not present, I would immediately start CPR and ask for help.
How long will you take this process to go on? How much time do you need to confirm that patient has arrested?
10 seconds.
Yes, well done. So you look, listen, and feel at the same time for 10 seconds to make sure that patient has arrested. So once you establish that there is no pulse, patient is not breathing, and there is no chest movement, and patient is not responding, so that means he has arrested. And you have seen just now that he had VT on his monitor, and he has now arrested. So Rao has clearly said he would like to have some help. So you
Yeah.
call for help, and what do? You started CPR. Yes, Rao?
Yeah. Yes, that's
So what would be your rate of CPR?
my rate of CPR would be 30 compressions to 2 breaths.
Well done.
And yes,
Okay, so you have called for help. You've started the compression. Memuna, can you tell me the landmarks of the CPR, where would you do the CPR and how would you know that it's effective? Anybody else? Any volunteer? I don't know whether people can hear. Seher, your mic is on. Can you tell? Where would you do the CPR? Can you tell the landmarks?
On the sternum in the intermammary line.
Internal memory, which
At
line, sorry? Sorry? Okay, sorry, I can't hear. So yes, you do the lower half of the sternum and you do it with your palm of your hand clenched like this,
in the
and then you do the CPR. So you started the CPR. So looking at the algorithm on the ALS protocol, can someone tell me that which side of algorithm are we in? Are we on the shockable side or non-shockable side? Gulizara?
The patient has a pulse, so it has a
Patient
rhythm.
has got no pulse. He arrested.
We are not on the shockable side then.
So you have
So VT and VF are the shockable sides. So patient needs a shock. Okay. So last time I explained, when you got PEA, pulseless electrical activity or asystole, then you are on the non-shockable side and you continue the CPR for 2 minutes. Okay. So you have got now VT. So VT and VF, they both are the shockable side of the algorithm. So your first priority is to deliver shock. Okay. I think, yeah, Mohammed is trying to show you the shockable side. So VT and VF, your priority is shock. So Mahmood, can you tell me a little bit of procedure, how you deliver shock and what should be happening in that time period while you are charging and, you know?
Yeah, sure. During the charging phase, we have to continue the chest compression. During the charging phase, we have to select the energy, and once we have to select the energy, and when we are about to deliver the shock, so we must have to say all clear, me clear, you clear, and all clear. So at that time, we have to just stop the chest compression. So after that, we have to deliver the shock, and after delivering the shock, we have to immediately resume the CPR.
Okay. So when we decided that patient has arrested, we confirmed for the 10 seconds that he has got no pulse, and then we started CPR. Then obviously his GCS was 3. Agreed? So on GCS of 3, obviously he cannot maintain his airway. So because everything happens simultaneously when we are dealing in situation, so we need whoever called the help and started the CPR, their first priority is to maintain the airway first and carry on the shock side at the same time. But you need to make sure, because patient will not be able to hold their airway. So either you need to do the maneuver, head lift, head tilt, chin lift, put some oropharyngeal in their mouth. And when you say 30:2 compressions versus breaths, then how will you deliver the breaths? How will you deliver the breaths, Mahmood?
If we have if we don't have a advanced airway, so we will do 15:2.
No, 15:2 for children.
Okay, 30:2.
So 30:2. So, but you will do with the bag mask valve. So put the oropharyngeal in to secure the airway, bag mask valve. So one person is doing the CPR and one person is holding the airway. Now at this stage, because you are maintaining patient's airway with your own support, you know that he's going to have definitive intubation or, definitive airway. Yes? So you will call the anesthetist at that point because that patient needs airway supported. But for the in the meantime, while you are dealing with that situation and they're not here, you can still hold their airway in a good position and you can, deliver oxygen by bag mask valve. And you put the CO2 probe to check their end-tidal CO2. Okay, so that it tells you that how effective is the breathing. So one person is doing that. The other person was doing compressions. So as soon as your chest leads, your chest pads are on, you assess the rhythm on the monitor and they are in VT, right? So you deliver the shock, 200 joules. You deliver the shock, as you said, everyone clear, make sure that everything is away, oxygen away, make sure the safety of every member of your staff, and then you deliver the shock. As soon as you deliver the shock, what do you do? Rao?
Okay, so first we deliver the shock when we are all clear, like nobody is touching the patient or
Yes, so you
the
have delivered
operator.
the shock, you have given the shock.
Okay,
What would you do immediately after that?
immediately start the CPR. Immediately
Well done.
start the CPR.
Well done. So you go back onto the chest again and start the CPR again. For how long?
For 2 minutes again.
Good. So you will do the CPR for 2 minutes. So now you have got time to
Yes.
go through some important factors that can be reversed. And you know which one are they?
The reversible causes of cardiac arrest are 4Hs and 4Ts.
Well done.
And yes, and those include the hypothermia and
Yes.
And hypoglycemia and electrolyte imbalances, hypocalcemia,
Yes.
hypomagnesemia, and
Hypoxia.
hypoxia. Yes, hypoxia. And fourth H
So if you
is
keep that frame of A, B, C in your mind, then first thing is A, which is hypoxia, right?
okay.
That
Okay.
keeps you in a methodical way. So you've got hypoxia, you've got oxygen on, and you are treating with bag mask valve. So you are treating hypoxia, right?
Yes. Okay.
Then comes B. B means circulation, breathing or uske baad circulation. Then that can be hypovolemia. So for
Hypovolemia.
hypovolemia, you have already started fluids.
Right.
Then
right.
in D, it can be exposure hypothermia and then electrolyte imbalance, which can be hypoglycemia, hyperkalemia, hypokalemia. So in this
Yes.
case, you have in these 2 minutes, you have got time to do the 4H and 4Ts. So by now you have assessed 4H. Can you think of any cause that might have caused him to arrest?
It can be due to hypoxia. Can be due to hypoxia.
Do you
because
think
he's
can
already,
hypoxia cause VT?
I mean, because of VT.
VT may have caused hypoxia, but I don't think
Yes.
hypoxia can cause VT.
No. It can be electrolyte imbalance that could have caused hyperkalemia. Could have caused.
Well done. So this is what I wanted to hear. So you have concluded that you are dealing with H, hypoxia. You are dealing with, B, there is, breathing, his chest is equal, moving fine. his hypovolemia, you have given him fluids, and there's no obvious bleeding or nothing that you can stop. So you come on to hypothermia, you can check the temperature. So the patient's temperature is normal, 36 point something, but you still cover them with a cover sheet with a blanket so that they don't get cold. Then you do the electrolyte check, which is the blood gas, which is most important thing. So you have seen, as you have said, that electrolyte imbalance can cause VT. So you have done a blood gas and you have realized that his potassium is above 8. So does that make sense that you have picked up the cause of his VT and then to arrest?
Yes.
So now you have to treat that, the problem that you have found,
Yes.
right?
Yes.
So at this stage, although we are continue to do CPR, although we are going all through the algorithms, but the point is that you continue to treat the things that you find all along your way, which can be the cause of the cardiac arrest, right? So
Okay.
what do you give if it's got potassium of 8.9? What would you like to give?
I would like to give calcium gluconate 1 gram IV stat. And
So that's 10%, 10 mils of 10% calcium gluconate.
Yes. And then I would
What
like
else
to
can you give?
do the D-potash with
ACL.
with
Anyone else want to say? Carry on.
Insulin 10 units and 25% dextrose water 100 ml and 1 ampule of calcium gluconate in the infusion.
That's fine. So you know what to give. That you don't necessarily need to know the doses because you've got BNF by your side. You've got, your other things that you protocols, they have written everything. But the resus trolley, I think it's a good idea to have a resus trolley in your department, which you might be already having, and they have got resus drugs in them. So you've got a stat KCL injection, which you just give like that, because you don't have time to run through the drip of potassium or act rapid or all that thing in that. So by the time you were doing that, you have assessed his 4H and it's now 2 minutes up. So what will you do? I need to ask somebody else now. Who wants to tell me that 2 minutes are now up?
Check the rhythm.
So check rhythm, check for the pulse. So you check for carotid pulse.
Yeah.
And there is no pulse. And you still see VT on the monitor. So it's a pulseless VT again on the monitor. So what will you do, Kulizara? Which side of the algorithm are you still in?
We are still on the shockable side. We can go to adrenaline every 3 to 5 minutes, and if not that, then we can go to amiodarone after 3 shocks.
So after the third shock, now we are doing the second shock. So because now this is a second cycle, so we are going step by step. Okay, so we're going second. Now is check this pulse again, VT, no pulse. So it's time to deliver second shock. So you go for 300 joules, second shock, right? And then as soon as you deliver the second shock, what will you do?
Start the CPR again, and someone would be meanwhile giving adrenaline, a shot of adrenaline.
Okay, so good. So it's not the time of amiodarone yet. Amiodarone comes after third shock. So far, we have now given 2 shocks. So now we've got 2 minutes again for the CPR. What else can we check? We still have got more things that we can reverse.
You can check for the 4 T's because we have gone through the 4 H's.
Yes, well done. So what are the 4 T's?
It could be tension, pneumothorax, toxins, or it was tamponade. We can check for tamponade as well. So if any one of that is present, so we can reverse that.
And thromboembolic, like pulmonary embolism, right? So in this case, VT, when you looked initially assessed, patient is when you give breaths, but with bag mask valve, you can listen to the chest on the lateral end so that you know that equal entry bilaterally. So that means there is no tension pneumothorax, right? And you have got no obvious history of any toxins, so it would be very unlikely. Pulmonary embolism can be, but I don't think with the VT, normally they've got different rhythms and it's not looking like the case of a pulmonary embolism. And the tamponade is also not in this case because obviously you have found the cause of the cardiac arrest. So in the meantime, you have given 2 shocks and patient was in VT and now it's 2 minutes and you have checked 4H and 4Ts. So now 2 minutes are up. Mahmood?
After 2 minutes, we again have to check the pulse. If the pulse is present, then we have to check
So
the
there is
rhythm.
no pulse.
So if there is a no pulse, then we again resume the CPR and we again ready the shock.
Okay, but you
And
have you checked what's on the what's the rhythm on the monitor?
so if the pulse is not present, then I will not check the rhythm.
You if there is no pulse, but there will still be a rhythm on the monitor.
Okay. If there is a rhythm, so it might be a pulseless electrical activity.
So if you see on the monitor when you stopped your CPR because there is a 2-minute time and you check for pulse and there is no pulse, but you see on the monitor, you can see normal PQRS's complexes. So what would that be?
So it may be a pulseless electrical activity, PEA.
Well done. So which side of algorithm are you in?
So now I am on a non-shockable side.
Well done.
I have to do
So what will
CPR.
you do? Continue
I
CPR.
have to do CPR.
Good. So I think this is how you carry on. So you move from the shockable side to the non-shockable side and carry on doing whatever you can reverse. Okay. So you decided that it's non-shockable side, you give adrenaline, right? And then in the meantime, you have to have now intubate the patient. So you've been doing this exercise for like every 2 cycles, continue, and then checking the pulse and there is no pulse and you start seeing a literally straight line. Then what does that mean?
So
Asystole.
straight line mean asystole.
Asystole. So asystole, what side of algorithm is it? It's again
Non-shockable.
non-shockable. So during this time, there are lots of people who are involved, who are doing the CPR, which as a team leader, one person will be standing at the foot end of the patient and managing the whole situation. Whoever is doing the CPR, you have to make sure that they don't get tired, because with the tiredness, the effectivity of CPR reduces. So you make sure that you keep switching people. So there should be 2 people, one on standby and the other one doing the CPR. So when you do, one person is doing CPR, make sure that they don't get tired and quickly switch over by the time when you check pulse, or if you're about to deliver a shock, or when you are delivering a shock and back onto the chest, then make sure the fresh person do the CPR. So it's a little bit of, communication or looking after your own team to make sure that everybody is doing their job effectively. So it's been an hour and a half since you've been doing this whole exercise, but there is no pulse, there is no return of spontaneous circulation. In the meantime, what information can you gather?
You can check for previous medical history, the drugs the
Yes.
person was on. Since he presented with hyperkalemia, he could very well be on beta blockers or angiotensin inhibitors. So we can check for past medical history in the meanwhile.
Yes. So we can check their comorbidities. We can check their, he's 70, what's his quality of life? what other comorbidities he have, diabetes, hypertension, what to what extent, what's his medication, what's his allergies, what's his quality of life. Can he do most of the things? Is he bed bound? How much you can improve by doing all this exercise, right? So if you have done this exercise for an hour and a half and you have got no answer, do you think that prolonging this is going to make much difference? So at what point, sorry, Gulizara, so
When we are done with 3 cycles of CPR, and we know that by this point 20 or he had some comorbidities, I think that is the point when you step back.
so that's I agree with you. Until you know what are the comorbidities, what's his baseline, and if you have decided after the 3-4 cycles that he's not going to make it and his quality of life is really poor, but it's always worth continuing while you have got definitive effort of making patient better. Then in the meantime, somebody will be having a chat to the family. We have to involve the family, okay? Not taking their permission, but we need to involve them in the discussion that he is not going to make it. Okay, and then with the mutual decision of your all team members, whoever is leading the team, they will decide that this is not going to affect, this is not going to help, so I think we should stop. So everybody's consent should be taken. If any one of the member of the team say, no, I still want to carry on, there might be something that we have done, let's try this. So worth giving, giving them the option that yes, or if you're not convinced, then you give them a reason that why you are not convinced. So you have stopped and patient has died. Okay. What comes after that? I think there are lots of people who are not participating, but listening, which is good anyway. Anybody else apart from the one who are participating? Rana?
Sorry, ma'am, what was your question again? I couldn't get you.
So once you have stopped and patient has died, what would be your next steps? What are the important things that you need to do after the patient has died?
Someone has informed the relatives. I think we discussed last time that the whole team needs to take a few minutes back from the clinical activity and assess the whole situation and how it went, how well the code was run, and to gain a closure on and emotionally they have to get a closure on how it happened. So because it takes a personal toll on everybody. So
Very good.
everybody
Thank
needs
you.
that.
Exactly. And the other important thing is the documentation of all the events, what exactly happened, how many cycles of CPR, what did you give, how much did you give, and how, the whole documentation, who was involved. Um, because I think you do have to do the death certificates or not, I'm not sure, but these are the important information. Anyone who dies should have a very good documentation of all the sequence of events, because patients' relatives have got the right to see that what happened and what not. So very well done. It was good participation. I think it must have helped. So I will quickly summarize the situation again. I think this time we only discussed about the cardiac arrest. That's why it took a bit long. We could discuss another scenario, but I think we should be discussing about the questions if you have any, because we've got 15 minutes left. If you start the next scenario, it's going to take a long time. So yes, when you see a patient, start ABCD approach. You don't necessarily need to know the cause to treat the patient. Start your ABCD approach. Carry on treating the problems that you come along with them on the way of assessment. Assessing a sick patient, assessing a peri-arrest patient is very important. When you know that this patient is going to arrest, has not arrested, but going to arrest. So this situation, recognizing a sick or ill patient is very important. So once you recognize, call for help, Then if the patient arrests, then follow the algorithm. Get the algorithm on the bedside, on the walls, so that you don't have to memorize everything. Go as the books say, shockable side, non-shockable side. Do, give the drugs at that time. I would suggest to have a resus trolley whenever somebody collapses, the whole resus trolley that contains, normally we have a resus trolley which has got 3 drawers, so for airway, breathing, and circulation. So everything in the top drawer is related to A, your intubation stuff, your oropharyngeal, nasopharyngeal. Then you go, face, bag, mask, valve. Then you go B, all the lines, and C, the drugs and everything. So all, and the defib is on the top of the trolley. So whoever does collapse, bring the trolley, crash trolley back to the patient, get that sorted. Everyone should be aware of what jobs they are doing, assign the roles. One person should take the lead. It's not necessary that the senior most person is responsible for the cardiac arrest. Anyone who knows the drill can run the cardiac arrest. So it's a good learning. It's a good opportunity to lead the cardiac arrest so that go through the things. Any questions from anyone?
I have a question.
Yes.
Sometimes we have a difficulty in the palpation of carotid pulse. Uh, we are a little bit confused if pulse is present or absent. So what will be our best response at that time?
So 2 people can feel the pulse, one can feel the carotid, and one can feel the femoral. So once you have got 2 opinions, if they match, then it means it's fine. Yes, I agree that one person has got maybe misjudgment, or because of the pressure, noise, nervousness, they can't realize whether there is a pulse or not. Then it's not just necessarily feeling the pulse. Is there any sign of life? If he has got pulse, is he trying to make an effort to breathe? If the patient is trying to make an effort to breathe, then that might help to suggest that maybe there is a pulse, but it's weak. But if 2 people are feeling the pulse, or you can put one hand on the carotid and one on the femoral, then you will have 2, but still there is one person's opinion. But 2 people, if they're feeling not the carotid on the both at the same time, of course, but one on the carotid, one on the femoral, the other person, then you will have 2 opinions. If they match, go along with that. Does that answer your question?
Yeah.
Any more questions from silent people?
Dr. Bushra, what's the difference between torsades and VT?
So I think once you have seen the VT and torsade, it's a complexes which are different on the monitor. Okay, and the treatment is also different. So if you, I mean, it's difficult to show you. I can try and make it for you.
That's
Can
okay.
you
I'll
see
pull it.
here?
Sure.
So the VT is polymorphic. It's go along with the same because the baseline of the same. I can't draw very well, but it
Sure.
goes, the height of the complexes are all the same. But when
Okay.
you see the torsade, it's a big complexes, and then it becomes smaller, and then it becomes like this again, and then it becomes smaller. So you got a complex a bit smaller. So it's not it's a polymorphic. It's not the mono.
I got it. Thank you.
So magnesium sulfate, I think you give magnesium sulfate in that case. But you normally have torsade. For that, you have to have a bit more changes prior to that. For example, prolonged QT interval. In people who are on some medication that can cause prolonged QT, that leads to this torsade. But if you go through the VT, when you found out the patient was hyperkalemic, then hyperkalemia has got more chances to go into VT. Any more questions?
Yeah, I have one more question.
Go on.
During the code, if I recognize the patient is suffering from the electrolyte imbalance, for example, hypokalemia, so at that time, we need to administer diluted potassium or undiluted potassium.
So when you see the rhesus trolley, I think I mentioned KCl before, but that's for hypokalemia. If you found hypokalemia, you give KCl. And if you got hyperkalemia, then you start treating the calcium gluconate and all that stuff. But KCl you give, I think is in that situation, you got not much to lose, isn't it? So you give stat doses because the circulation is really, really poor and you are actually doing the CPR to do the circulation for the patient. So you can't give the drugs for 20 minutes because obviously the blood is not running. So you have to give the stat doses of everything because you just want to push, rather give the stat dose and give a big bolus of fluid so that it goes into the heart and start to have an effect. Okay, so you don't wait for, like normally in a real person when they got hypokalemia, you give them 40 millimoles of KCl in 4 hours because it's not good for your heart. Your heart is already stopped. It's already dead. You just want a quick effect, don't you? So you just give a stat dose of KCl, give them potassium so that it goes into the blood, it goes into the stream, and you flush it with the fluid so that it can circulate. So you, in the cardiac arrest situation, everything should be stat.
Thank you so much. Can I have one more question?
Carry on. I'm happy to answer.
Okay. For example, I have an intubated patient and the cardiac arrest occur. So at that time, can I put a patient on the ventilator with 100% oxygenation and can I set a rate there? Instead, I have to take patient on a ambo bagging.
So basically, as soon as you get the anesthetist who can intubate, or if you are happy to intubate, the idea is to get definitive airway. You don't necessarily need to do the bag mask valve. Okay, because in ideal situation in real life it does not happen that quickly because drawing up the drugs, um you muscle relaxants, or even in cardiac arrest intubation, getting the trolley ready, everything takes time. So you buy time by doing the bag mask valve, and basically you are keeping your two staff members occupied, one with holding the mask and the other person is doing the bagging. So you need to release them. You need them for something else, don't you? So
Actually,
sooner you get the intubation and get them onto the ventilator, the better it is.
no, my question is that कि अगर मेरा पेशेंट जो है वो ऑलरेडी वेंटिलेटर पर है और उसको कार्डियक अरेस्ट हो चुका है तो फिर मुझे उसको वेंटिलेटर पर ही रखना है या फिर
हाँ,
मुझे उसकी
क्योंकि वो तो
मैनुअल
ऑलरेडी
ब्रीथिंग करनी है?
इंटुबेटेड है। हाँ, वो तो उसको तो फिर आपने ऑलरेडी, वो तो आपका इंटुबेटेड तो पहले ही है ना, तो इट मींस कि उसका एयरवे तो ऑलरेडी इन लाइन है। मगर द क्वेश्चन इज कि आपका इंटुबेटेड पेशेंट अगर कार्डियक अरेस्ट में चला जाए तो डू यू रियली वांट टू डू अ सीपीआर? तो आपको उसके लिए कुछ बातें जाननी जरूरी होंगी कि व्हाई इज ही ऑन वेंटिलेटर ऑलरेडी, राइट? हाउ मेनी डेज इज ही ऑन अ वेंटिलेटर? Is he for resuscitation? Have you decided his resuscitation status when you put him on a ventilator? If somebody has already got a major head injury and you intubated him and it's day 5 and they're not having any response, if they arrest, is it wise to do a resuscitation? Is it wise to do a CPR on him?
Yes, you
Not
are right.
really.
Yes, firstly, we have to see the patient prognosis.
Yeah. So you have, once you put the patient on a ventilator, you and the patient goes to ITU, and or even if they are with you, then you start thinking about the treatment escalation. You decide about thinking how far you're going to go if things deteriorate, because we think about the worst scenario. We think about the worst case scenario, that worst can happen. And in that situation, what we need to do, what will we do? क्योंकि ये चीजें उस वक्त तो डिसाइड नहीं होती ना जब ये कुछ हो जाए, तो उस टाइम तो आपके पास टाइम नहीं है डिसाइड करने का. इफ यू हैव ऑलरेडी डिसाइडेड, हैव अ डिस्कशन विद द फैमिली एंड यू नो दैट देयर इज पुअर प्रोग्नोसिस, इट्स नॉट गोइंग टू मेक एनी एफर्ट, तो आप उस वक्त पहले ही उसका डू नॉट रिससिटेशन फॉर्म आप उसको मतलब उसका डिसीजन तो कर लेंगे ना. सो इन दैट केस you may not need to do a CPR because patient is already on a ventilator, you know, he's already half gone, and you are managing him with support or drugs or mechanical ventilation. So this comes, I think, you in the emergency department you hardly see such patients who are already intubated. This is more of a case in ITU or in ward, not in the ward, obviously in HDU when the patient is already intubated. So it's another discussion which we will do at some point in the some other session, that how we make a decision of do not resuscitation. So well done, and thank you very much for your participation. I think we
One
will
thing I
stop
wanted
here.
I just wanted to
Yes.
add one thing to
Yes.
Mahmood. The only thing is that if the patient is intubated and the only time you take the patient off the vent and start ambu bagging is if you think that the endotracheal tube is blocked by secretions, or if the O2 sats have been progressively going downhill. Even when on the vet आप 100% के ऊपर हैं, फिर भी उसकी saturation जो है वो barely maintain कर रहा है और फिर एकदम गिरती होती है. And the main thing वहाँ पे होता है कि जब hypoxia induced होता है ना, तो आमतौर पे bradycardia में patient जाता है. तो अब वो 100 डिग्री या 120 पे है हार्ट रेट पे, तो वो 80 पे आएगा, 60 50, और फिर वो साइन वेव जो होती है या वो हाइपरकलीमिया में होता है इस तरीके से. तो उस वक्त आप जब आप इफ यू आर थिंकिंग दैट द एंडोट्रेकियल ट्यूब इज गेटिंग ब्लॉक्ड विद सिक्रीशंस या उसको सैचुरेशन मेंटेन नहीं करे, तब आप वेंट से उतार के फिर आप रैपिडली अम्बू बैगिंग करते हैं उनकी. ठीक है,
और उसमें
That
उसकी
is the only
एंटाइडल
thing.
CO2 भी कम हो जाएगी ना, क्योंकि अगर आपने उसको इंटुबेट किया हुआ है और अगर उसकी ट्रिकल ट्यूब ब्लॉक हो रही है या एंडोट्रिकल ट्यूब में कोई गड़बड़ हो रही है, तो जो कुछ आप अंदर भेज रहे हैं ऑक्सीजन वो उस तक नहीं जा रही और ना ही उसकी कार्बन डाइऑक्साइड बाहर आ रही है. तो इट मींस देयर इज सम ब्लॉकेज ऑन द वे. सो देयर आर टू पैरामीटर्स, यू सी द सैचुरेशंस के जितनी ऑक्सीजन अंदर जा रही है वो नहीं जा रही और कार्बन डाइऑक्साइड को बाहर आना चाहिए, तो यू एंटाइडल CO2 इज नॉट पिकिंग अप. So it means there is a blockage somewhere. You need to clear the blockage. So as you do all the reversible causes, ये नहीं कि आप मतलब अगर पेशेंट का डिटीरियोरेट हो गया तो आप उसको फौरन ही छोड़ दें, और बेशक उसका डू नॉट रिससिटेशन फॉर्म आपने साइन किया हुआ है, दैट डज नॉट मीन कि आप उसके रिवर्सिबल कॉजेज को आप ट्रीट नहीं करेंगे. यू विल स्टिल ओपन हिज सक्शन करेंगे आप उसको, ट्राई एंड मेक इट बेटर. वो तो मतलब वो तो एक्सट्रीम केस सिनारियो कि उसका हार्ट रेट भी खत्म हो जाता है, उसकी पल्स भी खत्म हो जाती है, वो तो फिर एक एक्सट्रीम केस हो गया कि तब आपने क्या करना है. लेकिन इस सिचुएशन में यू ट्राई टू रिवर्स द कॉजेज, क्योंकि ये ट्रीटमेंट एस्केलेशन में शामिल नहीं है. दिस इज अ रिवर्सिबल कॉज विच यू कैन ट्रीट एंड इट्स नॉन इन्वेसिव मेथड ऑफ क्लियरिंग द एंडोट्रेकियल ट्यूब बाय सक्शन और क्लियरिंग द एयरवे सिक्रीशन जो भी उसकी आ रही है. ठीक है.
One
May I
other
add
question
some?
I have for the people is that when you get a definitive airway and endotracheal tube आपने डाल ली है और आप उसको आपने endotracheal tube वाली है, what will be your ratio of CPR to breathing?
I was about.
Very important question.
So you continue the compressions. You don't need to stop for the breathing.
Well done.
Because
obviously अब आप breathe तो कर ही रहे हैं ना पेशेंट को, तो अब आपने breathing को maintain कर लिया, तो फिर there is no need to do the 30s to 2. It's only for when you are bagging the patient. Once you got definitive airway, then it's a continuous CPR. You only stop to check for the pulse every 2 minutes and do according to what the ALS guidelines say.
Good.
Did that help?
Yes, definitely better session than the previous sessions, and I definitely liked it.
So I think this is a good effort. Well done. I think it's very important कि आप लोग participate करें. आप लोगों के फायदे के लिए है और लोगों को भी बताएं, आपकी नर्सेज को, ये सब लोग जब आप एक टीम के साथ आप इस तरह से काम करेंगे तो you will save more lives. You will feel much better in yourself as well. You will feel more confident. तो I think हफ्ते में 1 घंटा निकालना is not a very big deal. और जहाँ से भी knowledge मिलता है इकट्ठा करें. ठीक है ना? तो
Yeah, let's
इंशाल्लाह फिर
decide on the next topic. We can text each other on the forum and decide on the next topic. And
Okay.
the next session will be on Wednesday, the 24th.
That's good for me.
Is that at 9 p.m. again, the same time, inshallah. Thank you very much for everybody's participating.
Thank
Okay?
you very much. I appreciate. Thank you very much. Have a good evening. Allah
Thank you so
Hafiz.
much.
Allah Hafiz. Allah Hafiz.
Allah Hafiz.